All right. How did that go? Great. Remember how to do all that? Still finishing up there. So today we're going to cover mostly pulmonary. I hope we get through it all. We'll see. Do we have what's this from? Is this a pin in your finger?
Yeah, I wish.
We'll have to see where that. Yeah. So hopefully we'll get through everything today. I love teaching cardiopulm. I love patients with cardiopulmonary disorders. I think it can be a little tricky, but I think this is one area that I think a lot in the physical therapy world we cut corners on the cardiopulmonary system. And you guys have heard me talk about if I have a woman coming to me with an ankle sprain, if they have osteoporosis, I'm spending a lot of time talking about osteoporosis and prevention of falls and strength training and the benefits of impact. I'm spending a ton of time with that. If we have a patient who's obese, we're going to talk about the benefits of dropping weight and what that could possibly do for their musculoskeletal system if that's what we're seeing them for. So there's some conversations we have that are indirect. You know, they're here for their neck pain or whatever else, but hey, I also see this in your chart. We should talk about this at the very least. And I think at the very least, when we see patients with risk factors of cardiopulmonary, we can give them some advice, because if the cardiopulmonary system isn't functioning well as we get older, it significantly impairs our life or ends it. So I think we have a huge benefit, a huge opportunity to impact the overall health of our patients with just some of this knowledge. Now, there's 8 of you going out to clinicals in a skilled nursing facility or hospital next, I think. 4, 5, 6, 7, 8. I think there's 8 of you. And then the rest of you will be doing that in your final rotation. So more often in those settings, we're going to get patients who are there directly because of an impairment in their cardiopulmonary system. So actually, you could probably tell us, how many times do you see people in the skilled nursing facility just because of pneumonia? All the time, right? Never mind heart attacks. Kate, how many cardiopulmonary patients did you see at Spalding? A few, yeah. How about the rest of you in your rotations, your first rotations? Any cardiopulmonary specific? Probably comorbidities, as little as high blood pressure, right? So that was, I mean, everybody, right? So in your next 2 rotations, there's going to be some patients that are there specifically because of impairments in the cardiopulmonary system, and we're going to have to directly treat that. I think for a lot of patients, it's a secondary thing, and when we'll just have a conversation about that, give some advice along the way, try to encourage healthy behaviors. We'll talk about that a lot too. So today we're going to focus mostly on the pulmonary system, and hopefully we do a good job, and hopefully we get through a good amount. Do we get a lunch break, by the way?
11:30.
11, that's an early lunch, huh? All right, somebody's got to keep me on track, because I'm going to be buried in this stuff. So somebody can just kindly say, hey, it's getting close to lunchtime. All right, so we have I'm not going to go through the anatomy. You guys have taken anatomy, and we're not going to spend a ton of time on that. So, you know, that's there for your review. One thing I do want to point out, right lung has 3 lobes, left lung has 2 lobes. And when we talk about, we also have to remember they're also 3-dimensional. So there's anterior and posterior sections of it. And especially when we start talking about secretions and different pneumonias and where is this mucus building up in the lungs, we're going to have to know about the lung anatomy, broadly speaking, at least. And then the lungs break down into different segments as well. This airway tree breaks down. It has, I think, 26 or 28 different set breakdowns of it. So it branches out quite a lot. Hopefully some of these terms we've used before, and some of them might be new. Eupnea is just normal breathing. That's our 12 to 20 breaths per minute is the norm for adults. Kids, anybody remember the norms for kids? Slightly faster. Yeah, about infants. Slightly faster than that. Yeah, so that's a good way to think of it. I don't have the exact numbers in me, but as long as you can know they're a little bit faster, then I think we'll be all right. Apnea, absence of breathing. Tachy and Brady, we already know. Hypernia is increased rate, and hypo is decreased rate. So you might see some of those terms. Sleep apnea is where a person stops breathing at night, too shallow to have sufficient oxygen perfusion. Usually cause the person to awake at night, might require nighttime oxygen, might require some sort of supplemental pressure system like a CPAP. Cheyenne strokes breathing is patterns of irregular breathing. This is usually due to damage of the respiratory centers. There's a little graph of it too beside us. So, go. That's kind of abnormal patterns. We have ataxic, which has irregular depth. And next semester, when you guys dive into neuro a little bit more, you'll learn different sections of the brain. Cerebellar controls some of the motor function and coordination. So if we have cerebellar damage in the brain, that can cause irregular breathing patterns. Biot's irregular breathing varies in depth and rate with periods of apnea, often associated with intracranial pressure or damage to the medulla. Apnorestic is prolonged inhalation phase. So we have different breathing control, voluntary, involuntary, primitive, and chemoreceptors are all going to help us figure out how to breathe. And when I say figure out, the body just does it automatically. But breathing is a little bit different than heart rate, where we can say, okay, take a deep breath now, and we can voluntarily take a deep breath. It's a lot harder to do that with increase your force of your heart contraction. That's not really a voluntary thing we can do. But with breathing, we can. So here is a picture of lung volumes. If we were to have, I have a picture. Oh boy, where did that picture go? All right, so way down here. So in this machine here, this is electric spirometry. So if we had someone breathing into a machine like that, that was a cartoon. I don't know if you guys recognize that. But if we had somebody breathing into a machine that could measure lung volumes, that's where we're going to get this information from. So a lot of our patients are going to have this data. This isn't necessarily something we do in physical therapy, although I wonder if down the road we would be doing this more and more often, especially with physical therapy being at the doctorate level now. I'm wondering if tests like these are going to enter our world in the next couple of decades. I'm just thinking out loud. Right now, it's not. But we can cue someone how to breathe in a machine and collect that data. That's not something that we can't do. Yeah.
But they do like when you blow in and test your.
Oh, yeah. So there's different tools that we can do to test a few different things that we'll get into. The spirometry is where we're going to get this chart and this information. So there's a few things to be really aware of, because there's terms that we're going to be talking about, and especially when we talk about diseases that restrict this lung volume or how this works. So tidal volume is just our normal volume of air breathed in and out. Just tidal volume is how you guys are breathing right now. Your normal breath in and out, just how much volume, if you were to have a balloon, how big is that balloon of air you're drawing in and blowing out? Inspiratory reserve volume, IRV, That's additional volume of air that can be inhaled with maximal effort after normal inspiration. So everybody can breathe normally right now. And then what I want you to do is breathe in all the way that you can. So normal breath, and then, right, all of that air I just sucked in, that would be my inspiratory reserve volume. Expiratory reserve volume is the amount of air that can be forcibly exhaled after normal exhalation vital capacity. So from here to here, expiratory reserve. So your normal breaths in and out, and then how much more air can you get out after your normal air? Vital capacity is the amount of air that can be exhaled after maximal inhalation. So breathe in all the way, then breathe out all the way. That's just the total amount of air that can pass in and out of your lungs. Residual volume down here, there should be some air left behind. What we want a little bit of air left behind, because if there's not air left behind, the lung could collapse on itself, then we can't be getting air in and out. So there should be amount of just an amount of air that's just left behind for that reason. The heart has the same thing. There's a little bit of blood that's left in the heart after a contraction. We call that preload in the heart. Total lung capacity is now I'm adding my residual volume all the way up to my inspiratory reserve volume. That's just how much air can we fit in these lungs. We also, not on this chart here, we might also be able to measure things like how much air can be pushed out in 1 second. So now that's a combination of volume plus force. So forced expiratory volume in 1 second, FEV1, is a really common measure, and that might be something closer to what your clinicians are testing, because we can test that pretty easily with just a slide meter. Is that what it looks like? It's just almost a plastic slide meter, and it just like there's a dial that just moves out, and then yeah, that's probably what she's doing. But it's great. It's amazing to hear that she's doing that. So we would like the amount of air pushed out in 1 second to be around 80% of this vital capacity. So that's a good amount. That would indicate healthy elastic tissue that these lungs are taking in and then able to become smaller to exhale a bunch as well. And those are all those definitions there if you wanted to look at that. So technically, ventilation is external respiration between the lungs and blood vessels. Respiration is internal gas exchange in the blood and the tissues. We want to take in oxygen and get out some CO2. And that's where oxygen is going to combine with the hemoglobin. Muscles of ventilation is diaphragm, and I think there's a lot that we can teach our patients with diaphragmatic breathing. There's plenty of patients who do not understand how to breathe with their diaphragm, and if they're not using their diaphragm, they're only using their chest, their thorax. Well, we're only expanding our lungs in almost 2 directions, just anterior, posterior, and then lateral. With the diaphragmatic breathing, we can expand it downward as well, inferiorly, and that's really going to make a big difference as far as how much air can be brought in. Does anybody, just quickly, anybody have seen a patient or maybe a family member that has a lot of trouble breathing? Maybe they have chronic asthma, smoker, anybody on oxygen. Anybody see anybody like that? It is incredible when you start working with patients who can't walk to that door without taking 2 rest breaks. The amount of effort it would take for us, if we were to run 10 sprints in the entire parking lot and back, how breathless would we get? That amount of breathless is where a lot of patients have just trying to get off the couch and walk to the bathroom. So the how we can attack those problems is really going to depend a lot on the person, their disease process, but also I think if your patient has a breathing problem, work on posture, work on diaphragmatic breathing. If you can do those two things, you can impact them greatly. The rest of it we'll dive into a whole heck of a lot more. But if you can just offer those two things, then I think we can make a significant impact on our patients. So diaphragmatic breathing, really want to work on that. We'll work on that next, actually. We also have accessory muscles of inspiration, sternocleidomastoid, scalene, serratus, pecs, traps, erector spinae, anything else that can be used to expand the rib cage so that the lung volumes can then increase as well, abdominals, and then our intercostal muscles. Has anybody used their accessory muscles for breathing before? Yeah, I hope we all have. If we ran up and down, if we did those 10 sprints in the parking lot, after the end of it, what would we look like? Not Christian, because he's in such great shape, but what would we do? Hands on knees, go, right? So that's us using our accessory muscles of inspiration. So we're anchoring down our arms so that all of the muscles that are attached to my arms and my thorax, well, I keep my arms still and I contract those reversal muscle action. Now I'm going to be expanding the ribs, helping expand the ribs. And if I can expand the ribs, the lungs expand as well. And now I have brought in more air. So what I want to do next, let's see, we're going to work on diaphragmatic breathing. So we're going to skip all the way down to slide 85. Because you know me, I hate talking. So we're going to get our hands on some stuff and we're going to, oh boy. Oh boy, we got a lot of work to do today, huh? All right. All right. So a lot of the times our patients are going to function better. They're going to understand this better in the supine position. However, I got to switch this one. Hold on. However, the supine position for people who have trouble breathing is sometimes the worst position for them. There's just the weight of their chest, especially if if they have a lot of adipose tissue, it can be really, really tough. So supine's a great place to see it, but if we're increasing that dyspnea, that difficulty breathing, then we shouldn't put them. We can put them maybe into a Fowler, semi-Fowler position. We'll look at what those are a little bit, but those are reclined instead of just flat supine. But here for us, we'll do it in supine. So the easiest way that I can describe it, and who's taught pelvic tilts before? Who's had an awful time teaching their patients pelvic tilts before? If you've had to teach pelvic tilts, you've had an awful time teaching pelvic tilts. So this is one of those things where some people just don't get it. And that can be really, really tough. So you know me, I like verbal cues, tactile cues, visual cues whenever I can. And so the supine position offers us some of all of that. So if we put our hand on our upper thorax, and then our diaphragm is that dome-shaped muscle right underneath our ribs. So you want to put one hand on your diaphragm right underneath the ribs, one hand on your upper thorax. So let's all do a little bit of chest breathing. So expand your top hand as you breathe. All right, now let's do diaphragmatic breathing. So now our top hand shouldn't feel a heck of a lot, but our bottom hand should be moving in and out. So let's try that. So as is sometimes a little counterintuitive how when we breathe in, that belly should be going out a little bit, okay? All right, so here's the next way that I've found some success teaching diaphragmatic breathing. Keep your hands in this position. Give me 2 quick sniffs. Everybody feel their diaphragm just giving it? You feel that underneath there? That to me is the best, most successful way to teach our patients who are never going to get this. You know, how do we teach pelvic tilts? Well, I put my hand underneath them and I say, squish my hand with your back. I put my hand underneath them and I say, don't touch my hand with your back. That's the easiest way that I have found for teaching pelvic tilts. This is the easiest way that I have found to teach what is the diaphragm and where does it work and what should it feel like. This quick sniff has to come from the diaphragm for that quick inhalation. So that usually is the cue for that. So once they understand what the diaphragm is, now we can try to cue them and say, now when I take a deep, regular breath, I want to have that diaphragm be the thing that's moving. So try to keep your thorax still and try to keep your diaphragm to promote diaphragm for moving. So let's just do that here. After that little sniff test, did you guys feel how you can activate that diaphragm just a little bit better? Did you anybody here notice that? So again, for our patients who have trouble understanding this is usually a good thing. But what I want to do now is let's be the therapist and we'll have our classmates be the PTAs. I'm sorry, the patients. And we will place our hands on upper thorax and on diaphragm and try to assess their breathing. The great thing about the supine position is I can see my belly going up to the ceiling a lot better than I can in standing, and especially in seated. If I'm seated like you guys are, everything's just cramped together and it's sometimes tough to see. So let's get in the supine position. We as the therapist will palpate initially. Watch where our hand placement is, especially if you have a female patient. But once you as the therapist know, okay, yes, they are breathing through this diaphragm, you can cue the patient to how to do that next, okay? Slide 84, I think it was. No, it's far down there. Yeah, diaphragmatic breathing. Yep.
Wow. You have a great light on that.
Yeah, we have somebody missing from class set. So, yeah, tuck that thumb in. Yeah. There you go. Yeah. Yep. Quick sniff. Yeah. My microphone is on and we are recording, but I want to say, how are you? And how's the baby? Good. Wow. That's awesome.
Oh my God, you're a professional. Nice. I love that you got one.
Yeah, man. You are beautiful, Tony.
Okay.
Yeah. They can feel their head. Initially, you know. Oh, they can't feel my head.
Years away.
I mean, it looks funky. You can't. You should have assumed. I see black feet. It's kind of big, it's my matcha.
So again, I think for any of our patients with breathing issues, the vast majority of patients that I've found needs help learning how to breathe with their diaphragm. And if we can give them that, it's amazing when we can see, if you can do this kind of stuff, you get buy-in from your patients, which can be so important. When you guys were on your clinicals, did you ever see patient can only reach their arm up to here and use some joint moves, and all of a sudden they get 30 more degrees? What's the kind of expressions and things the patient says after we do that? Holy cow, I can't believe this actually works. So the pulmonary analogy to that is my patient who needs 2 rest breaks to walk to that door from where you guys are sitting. If we can teach them diaphragmatic breathing and then cue diaphragmatic breathing as they're walking, now they only need 1 rest break. That's the analogy that we get to have. Same thing for posture and all the things we're going to talk about. So this is one of those kind of magic tricks that we could play with. So auscultation, using a stethoscope to listen to lung sounds. Now, this is something that in the PTA world, I think you should have working knowledge for it. I think there are some scenarios in which this could be very, very important. But really, it's to, there are some ways we're going to be doing this to be really, really specific with our treatments. So when we listen to lung sounds, we can say the posterior left lower lobe has decreased breath sounds to it. Well, now we can add our treatments right to that left posterior lower lobe. And there's a few things that we could do for that. So I will say this is a skill that even in my career, I haven't had to use a heck of a lot, but the times you need to use it, man, it's really nice to have in your back pocket. And I've also called physicians and said, hey, doc, I'm not that great at listening to breath sounds, so I could be way wrong here. But what I heard was, and I would tell them what I heard, and then that gives them a little bit of knowledge to say, okay, let's send them for an x-ray right away, and then I'll see him, go get an x-ray first and then come back to here. Because just with my information, they could say, oh, yes, we'll go that direction. So it can be really, really helpful. Now, I will say, even with my limited, I have some experience with this stuff. I do not do it every single day. This is holy cow, I can't believe I have to do this today kind of a thing. But I gotta say, even with my limited expertise, and I should say it's more than a lot of PTs, but it's not just somebody that does it every single day. The last person I did it with, I said, I think it's this side. I think it's this section of the lung. They got an x-ray and man, the pneumonia was in that exact section. So I was doubting myself, but we shouldn't be. We're listening and we're identifying things we're hearing, and then it's up to somebody else to determine the severity or the next step for that. But we're just taking information and relaying it. So I should be a little bit more confident. I hope you guys can get a little bit more confident with just Yeah, you're just listening and you report what you hear, and it's okay if you're a little off. So using stethoscope to listen to lung sounds, if possible, patient is in sitting position for it. We try not to do it over clothing. From the apex to base and then side to side using the diaphragm of the stethoscope, we're going to instruct the patient to breathe in and out through the mouth with a slightly deeper breath. So we have 6 anterior locations, 7 posterior for each lung. So there's a lot of different locations here. Now, I will say different resources have different locations. I think, let's see, whoops. That's not what I wanted. O'Sullivan textbook, that's the big, thick, red, everything in the world about physical therapy. It weighs about 35 pounds. You know that book? That book has 3 anterior and 4 posterior locations for each lung. Score Builders, which is the one of the better, there's a few really good ones. That's one of the better ones, the licensure prep books. They have 3 anterior, 3 anterior on the left, 4 anterior on the right, and then 5 posterior for each. And then what I got this from actually last month, yeah, the end of last month, the beginning of this month, I did a advanced course, and this is what those locations are from. So there is a variety of locations that is common for us. But I use this because it was the most advanced, is from the advanced course that I took, so why not give it to you guys? So the thing to remember is, because if we go back to the anatomy of the lungs and how many different segments of the lungs are there, they branch all over the place. And it's not like bony anatomy where the olecranon's always going to be where the olecranon is. How many people, when they palpate bony prominences on other people, you say like, geez, your patella is way higher than what I thought most people are, right? So there's a variety of, every single anatomy, every single person is built just slightly differently. So these locations are non-specific. They're good enough when we listen to the heart sounds, because we're going to be trying to listen to each valve of the heart. We have to be really specific in our locations. Here we get a little bit of wiggle room, and the wiggle room we can see with different resources having different locations. But this is what we're going to be practicing with today. So the way we're going to do the best approach for this is to do what we call an S pattern. So I'm going to listen left, then right, and then I'm going to move down, right, then left, then I'm going to move down, left, then right, then I'm going to move down. So we want to always compare left and right immediately back and forth, because we're going to have slightly different normal breath sounds higher and different breath sounds lower in our airway tree. So you want to be comparing left for right, left versus right, then next section, left versus right, and then next section. We want to listen to a full inhale and exhale before moving to the next segment. So the bronchial and tracheal sounds should be higher pitched, heard both on inhalation and expiration with a slight pause in between. Heard over the manubrium and trachea. Bronchovascular, high pitched inhalation and exhalation without a pause between. And then vascular, low pitch, softer, primarily on inspiration and the first third of expiration. So let's do this for now. I just want to listen to typical lung sounds first, and then we're going to talk about what abnormal lung sounds might sound like. So what we're going to do, and you might have to switch, we can use other rooms, or you can step out there if you need a quieter environment. What we're going to do is we're just going to practice this. So again, we don't have exact locations here, but throw on your stethoscope. Make sure we're using the bell of the stethoscope. on skin if you feel comfortable with it. So if we can, that would be really nice. So removing as much clothing as you can so that we can actually see the anatomy and where are we doing this. But yeah, listen with a full breath sound, left or right. I don't care which side you start, but compare left versus right before you go down to the next location. Okay? And see if you can hear the differences in all of these. Again, this should be at the higher up, this will be in the middle, and then this will be at the lower. Okay? All right, let's spend a little bit of time with this one, okay? All right, so I think for the first time you do that, it can be tough. Like, what am I hearing? What am I not hearing? And I think we increase our difficulty when we're trying to do it over clothing, because then the clothing rubs as we move. And what is that a sound? Was that not a sound? Was that something that I shouldn't be hearing or should? So that can be pretty tough. But I hope that you guys could start hearing those different breath sounds. So changes in sound transmission could be due to pathology. Sound is filtered by air-filled tissues and amplified by liquid or solid mediums. That's why it's so important to understand down at the lower sections, it should be lower pitched and softer. And if we can hear those breath sounds clearly, that probably means there's some sort of fluid in there transmitting that sound a lot more. If you wanted to soundproof a house, you put more gaps in the walls. And actually, a soundproofed house, the studs are offset so that if we have drywall, stud, drywall, that's all solid, that sounds can travel through easily. Where a soundproofed house would have on one side, it would be drywall, stud, gap, drywall, and then on the other side would be drywall, stud, gap, drywall on the other side, because those breaks, that air-filled areas is what helps deaden sound. Sound can travel through solid structures and air-filled structures pretty well. So so that's where we're going to hear some of these negative effects later. So three types of abnormal breath sounds. So bronchial, tubular breath sounds heard in the peripheral tissues. That's what I was just talking about. It also could be diminished or absent. None of those would be great. Other things that we might be able to hear, crackles, really common one for us. So low pitched, discontinuous. The example of crackles, also known as rails, Velcro sounding. Like ripping apart Velcro. The other one is rubbing your hair between your fingers. I have less and less hair each year to do that. So I think maybe Alan could with his beautiful head of hair. But for me, I get less and less. But that's another way to describe it. So either that Velcro coming off or rubbing on that Velcro or the hair between your fingers. Rhonchi, obstructive process in larger airways, low pitch and continuous, heard on inspiration or expiration. Almost sounds like a snoring sound. Stridor, continuous high-pitched wheeze on inspiration or expiration. Wheezes itself, bronchospasm, high-pitched continuous, heard predominantly during exhalation, whistling, hissing type sound. Pleural rub is a squeak on inhalation and exhalation caused by the rubbing of inflamed pleura. And then the other one is voice sounds, where if we ask the person to whisper counting to 5, we shouldn't hear that in the lower lobes, in the lower sections of the lungs. How many people heard really good breath sounds on the upper and then down to the lower, it was a lot harder, right? So as we whisper, We should not be hearing that through the stethoscope, but if we are, that's an indication that that section of the lung is filled with fluid, which is likely the easy example for us to think of is pneumonia with that. So that's a nice test that we get to do. But I think there's so much information we've got to get through, and there's so much to try to wrap our heads around. I hope that you can understand crackles, rhonchi, and wheezes are the most common ones that we would be talking about and we would be seeing. And those are all negative for us. We should not be hearing that stuff. You can look at this website. I think it worked last time I tried to use it. Not going to work today. Nice. So we got a bunch of different, let's see. Hear that little bit of rumbling almost? Yeah, so that's an okay example of some crackles. You can go through a whole bunch of different sounds there. So this is a pretty good site that you get to hear. Geez, look at all that. So feel free to spend some time with that stuff. Jeez, how did that happen? There we go. So we talked about electrospirometry, where that is a test that we get to use, also known as pulmonary function test. That's what this picture here is with this person breathing, and it's printing out a chart. That's that first chart we started looking at. Now, spirometry is something we'll talk about later, especially encourages deep breathing post-op to prevent atelectasis. So atelectasis is partial lung collapse. That's probably one of the major things that we see, one of the major conditions that we see, and something we want to also prevent, especially if our patient is going to be bedbound for a little while. And that's what that is. We'll get into more in depth with that later. Other lung tests we might be able to do, peak expiratory flow meter. Is that similar to what you guys are talking about? Yeah. So this is where the patient just gets to put this mouthpiece in and exhale as hard as they can, and it just shows you how much volume is going out in that deep exhale. So that could be something that we could use, and that's actually a really nice test for our asthmatic patients, for our patients with asthma. If the patient understands what their norms are typically, they can start looking at, oh, I feel something coming on, let me do this. They can almost self-test and self-say, oh, my breathing is getting worse. I'm about to have an asthma attack. What can I start doing to minimize that? We could look at blood gases and look at how much O2 and CO2 is in the blood. That's not necessarily something we would be doing in the physical therapy side, but especially if you're working in a hospital, that they're going to probably have some things embedded so we can directly measure this stuff right in there, right from their blood. So normal pH of the blood between 7.35 and 7.45. Respiratory acidosis is a rise in pressure of CO2. Chronic bronchitis is a usual diagnosis that would create that. Respiratory alkalosis is reduction in the PaCO2, which is pneumonia is a good example of that. We could also see chest x-rays. X-rays provide an image of the anatomy. And I certainly, my reading of images is extremely limited. But people who are better than me can start identifying, okay, here not only do we see the osseous structures, the bones, the ribs of the thorax, but we can also see the location and size of the heart. We could also see location and size of the diaphragm. We could also and position of the diaphragm, but we could also see if lungs have fluid in them. We could see that with an X-ray. Not as clear for the layman's for us and for our patients, it sometimes can be really, really tough. But for our radiologists, they do a great job picking that up. MRIs potentially could be used. Bronchoscopy, which is the shoving of a tube down the lungs to take a look around. That's pretty fun. We could also look at exercise tolerance tests. So 6-minute walk test is an easy example of that. We've done a 6-minute walk test in this building. We could also do a graded exercise test. The Bruce protocol is one of the more common ones. That's a treadmill test with heart monitoring. We're going to get into exercise stress tests a lot more in the cardiac section. But if we did an exercise stress test, there's kind of two different versions of exercise stress test. So exercise stress test with the lung attachments to it, where they have to breathe in and out through a tube, and that's going to measure all of your lung volumes and all that. Or that's an exercise stress test without that lung piece. There's most of the time they're done without that lung piece because we're only looking at the cardiac system. But if we want to incorporate the pulmonary, they have to wear either a mask or have the tube in their mouth. Who's done exercise stress testing before? I think you have, right? Anybody else? You have too? Anybody else? Did you guys have the face mask that went around, or you just had to hold the tube in your mouth? The whole face mask? Yep. So that's really, really nice. There is a world where PTs and PTAs perform those a lot, and cardiac rehab we'll look at a lot more later. But I think that's something a little bit more specialized that we could definitely go into easily. We'll talk a lot about METs as well. Talk about it. Oh, right now we'll talk about it. Look at this. So I think we've talked about METs in our exercise class whenever that was, last semester, I guess it was. I think the easiest way to think of a MET is sitting doing nothing is one MET. And then METs are just how many times harder is this activity than sitting. So based on this example here, is walking 3.5 times harder than sitting? Does that feel about right? Yeah, it feels about right. Let's see. Horseback riding versus walking, about the same energy expenditure? If anybody not been? You don't think so? No, well, not for the horse if you're on the back.
And my wife was talking about horseback riding, and it's not easy. It's not easy. Maybe like
Let's think cardiovascular. So not necessarily like your legs getting burned out, but cardiovascular wise. Your breathing rate and depth, is it about the same when you're on horseback than when you're? All right. Thank you. Thanks for agreeing to that. Basketball, roughly twice as difficult as walking. Yeah, I think that, right? So I think the easiest way to think of a MET is just how many times harder is it than sitting and doing nothing. Sitting and doing nothing is one MET. And then as the activity increases, it's just how many multiples harder. MET is defined as using 1 calorie per kilogram per hour. So that is the units if we wanted to. But again, I think the easiest way to think of it is just how many times harder is it. Playing rugby, 8.3 times harder than just sitting around. So other tests that we might be able to see, different blood counts. We'll look at that a little bit more with the cardiac as well. Hematocrits can be very important. What percent of red blood cells are going to be carrying the oxygen? So that could be really important for us as well. So more on the physical therapy data collection side, respiratory rate assessment, pulse oximetry, RPE, 6-minute walk test, 2-minute step test. Those are all things that we've done in this class. We did it. I just did it just a couple weeks ago in PTA 1. So if you can remember back to PTA 1, we did all of those things. So I'm not going to spend a lot of time on that right now. The only thing I do want to just underline for us now, when we have, it's one thing to take somebody's respiratory rate to make sure they're okay, that they're safe to exercise right now. And that's perfectly acceptable. And that's something we should be doing. When we have somebody with pulmonary conditions, it's probably more, another level of importance to assess is their type of breathing. So as we're assessing their respiratory rate, where are they breathing from? Are they all thoracic? Are they all lateral costal? Are they all diaphragmatic? So understanding where are they breathing can help us figure out what treatment do they possibly need. If somebody is sitting there and breathing with their diaphragm as I detect the respiratory rate, I might not have to spend a little bit of time to talk about diaphragmatic breathing. If they're not, I might have to spend a whole host of time talking about it. You guys that have had trouble teaching pelvic tilts to your patients, think of the person that you got really frustrated with and said, they just can't get it. And then they're going to come back on next week and they're just going to start all over again. They don't even remember what we did last time. How much time does it take, minutes, to teach a posterior pelvic tilt? So yeah, yes, you're absolutely right. But give me a time frame of like this person should understand it. Not they have Alzheimer's, they're not going to understand no matter what I do. But 5, maybe anybody take 10 minutes trying to do a simple posterior pelvic tilt and they still having trouble. So understanding, do I need to teach diaphragmatic breathing to somebody or not, is actually a big chunk of time that we might be able to save if they already know how to do it. Pulse oximetry, same. We're not going to spend time doing it. Just remember, it's unsafe to exercise below 90% unless there's physician-specific parameters that would change that. I've had some physicians tell me don't exercise below 92%, and I've had some that say don't call me unless they're below 82%. Okay, no problem, doc. If there's 0, I'll definitely call you. But yeah, I've had some patients that struggle to be above 90% just at rest, but they're still got to walk to the bathroom when I leave. So sometimes it can be really tough. But our general rule is that 90% mark. You work with some patients who they're constantly destatting all the time, and it's just like, God, we're not getting anywhere. Every few seconds we have to sit and take a break. You see that a lot, right? RPE we've talked about a lot. RPE, I think, is one of our best tools. I think we can use it for a variety of things, not just exertion as far as cardiopulmonary exertion, but I think it's also could be really good for balance. We want you to work. The general rule is everything we do in physical therapy should be somewhat difficult, somewhat hard. We can go down a little bit, we can go up a little bit. There's definitely, but man, if we could just teach somebody to be at that somewhat hard level for all of their exercise, we're going to get a lot out of that person. So how challenging should a balance exercise be? Somewhat hard. On a scale of 0 to 10 over here, we want you to be somewhere around 4 for this balance exercise. What about strength training? Well, we could do a bunch of math. We could do 1 rep max testing, or we could say exercise till it's somewhat hard. And that's going to be pretty damn good. So I love the RPE scales, whether original or modified. If I have a cardiac patient, I prefer the original just because it correlates with heart rate so well. If I'm really concerned of their heart rate or if they're on a medication that's blunting the heart rate response, we'll get to that next week as well. I love the original. Most people understand a 0 to 10 scale a lot easier than a 6 to 20. But again, I think the RPE, I think if we just taught you the RPE, if your whole exercise class was learning an RPE and say, well, here's a bunch of balance exercise, here's a bunch of strength exercise, here's a bunch of cardiac exercise, as long as we use the RPE scale and have our patients in a somewhat hard zone, we're going to be okay. We're going to be okay. There's definitely plenty of exceptions to that, but I think it's an underutilized tool that we could use for everything else in physical therapy. For stretching for range of motion. What should it be? Should it be so painful it brings tears to their eye? Should it feel like nothing? What should it be? Somewhat hard, right? So again, I think this is, if we could just really, if I could just implant that into your brain, I think I've done my job. Have I done my job? Let's go home. Happy Friday. 2-minute step test we've done. So that's where we take from the iliac crest down the popliteal space, midpoint. We mark that on the wall. Then they have to do this marching exercise to the level of that mark on the wall for 2 minutes. We count the number of times the right knee hits. 6-minute walk test is one of the most well-researched tests out there. And what I love about the 6-minute walk test is I can compare the data that I get from my patients to similar patients. It's so well-researched. You could find norms for 55-year-old females post-heart attack. You could find 72-year-old males with Parkinson's. You could really compare it to similar patients. Not all of our tests are so well researched. We have that vast of a database. So, but the 6-minute walk test is one of those. So again, all of our tests should be guiding us to a few different things. One, are we safe, right? So if I check your resting vitals, are you safe to exercise today is my first question. It helps me make decisions. So you know, your resting heart rate is this today. That means we're going to exercise to this level. We'll get to that next week. So it helps us make decisions. It helps us track progress over time. So if we did a 6-minute walk test or any of these other tests, what were you day one? And then after 4 weeks of therapy, what are you after that, right? We get to track progress over time. The other thing that can be really important, and especially as we're justifying to insurances, anybody in their clinicals have to write some documentation just to justify to insurance on more visits or anything else like that, right? So really, really important. So not only are we making progress from day one to what we are now, the insurance company says, well, you've made progress. How much more progress do you need? Well, I can compare my person to their norms. And for this 38-year-old female, it should be at this number, but they're only at 70% of that. So all of that is really important. So that's one thing that the 6-minute walk test is fantastic at. It just has so much data out there. It's so well researched. So there are plenty of other tests. 2-minute walk test is just a shorter version of the 6-minute walk test. Incremental shuttle walk test, that's another one. Treadmill or stationary bicycle testing. All of that stuff we could use for other tests if we wanted to. BMI is really important for us to understand. It's a height versus weight classification. So the flaws of it is can overestimate obesity in those who have muscular builds. But it can also underestimate body fat in older adults who have lost muscle mass. So that can undershoot the BMI for some of our older adults. But I will say, I think for a large percentage of the population, it's actually fine for. There's plenty that it's not fine for, but I think for a lot of people, it's pretty good for. And the reason I think it's important, one, the more adipose tissue around our chest and abdomen, the harder it is to breathe. So there's weight pushing down and not allowing that rib expansion. So that's number one. So that's why we talk about it in pulmonary. But two, something that's happening more and more is we are getting reimbursed based on the complexity of our patients. So complexity of the patients, we can be measured in a bunch of different ways. So yes, they're here for an ankle sprain, but they also had a heart attack 3 years ago. That's a much more complicated person than if they just had an ankle sprain. And I think BMI is one of those ways. It's a really easy and fast way that we can say this is a more complicated patient than someone who has a BMI at a lower level. I know for every single one of the patients in the home care setting, it's required data that I'm supposed to get, and we add that automatically. It's every single person. I know in the hospitals, patients are weighed all the time. And that's going to be for outpatient wise. Have you guys seen any BMI data inputted into your charts at all? How about not for you either there? So one thing, did you guys hear as at your rotations, have you heard any conversations on complexity of patients and justifying the complexity of patient at all? Yeah, you have, Reed. Anybody else? Yeah. So I think this is an easy way for us to document the increasing complexity of our patients with BMI. So if you haven't been seeing it, I bet you over the next 5 to 10 years, you're going to be seeing a heck of a lot more. All right, next one, Borg dyspnea scale. Let's see, where am I on my list here? All right, I'm where I want to be. All right, Borg dyspnea scale. So very similar to the RPE scale, except it's just about breathlessness. So how breathless do you feel right now? 0, no breathlessness at all, 10 maximum. So this is another tool that we get to use just to measure the difficulty of breathing, the rate of breathing. And it's patient perception rather than us just saying, oh, it's only 20 breaths per minute. That's within norms. It's high end of norms, but it's within norms. So I'm seeing on the licensure exam more and more questions on this dyspnea scale. And I think at first you should look at it and say, oh God, another tool to learn. Yeah. But it's basically the RPE scale just with breathlessness attached to the words. It's, what's somewhat hard, in that 4 mark. So it's very, very similar, just a little bit different. Good look at finger inspections. We talked about digital clubbing. Digital clubbing is a sign of chronic hypoxia, which has those distal tips of the fingers growing. I love gait speed as a measure. So the formal test is to have a 5-meter acceleration area, a 10-meter walking area, and then a 5-meter deceleration area. And then we get to calculate gait speed in meters per second. Community ambulators need to be above 1.0 meters per second, and limited community ambulators is going to be, the threshold is at least 0.6 meters per second. So community ambulators means you're all set, get out of here. Limited community means I'm a little worried about you crossing the street when that little person turns to the walk sign turns. Like, are you actually going to make it to the other side of the street in a timely manner? Now, I love using gait speed because it's so cut and dry. You walked this fast right now, that means you're limited or homebound or fine. So, and then our goals get to be created that are very cut and dry as well. But also, if we can, when we talk about person with pulmonary restrictions, trouble breathing, either because of disease or deconditioning, that person who walks from here to there and needs 2 rest breaks, if I can get them walking faster, never mind getting their lungs working better, never mind posture, diaphragmatic breathing, all the other things I'm going to do, never mind compliance with medications, all the other things we're going to do with them. If I can just get them walking faster, they're going to get there with maybe 1 rest break instead of 2, just because we increase their gait speed. So it's a way that we can really improve their quality of life, potentially. We're going to talk a lot more about sit-to-stand tests, I believe, in the cardiac portion as well. The 2 main ones are 30-second sit-to-stand. So all we do is, hey, this test only lasts for 30 seconds. I'm going to have you stand up and sit down for 30 seconds. I'll just count how many times you can do that. The 5-rep sit-to-stand is you only have to do this 5 times, and I'm just going to time how long it takes you. I love both of these tests. Again, they have some good norms attached to it. I also see a lot of good improvement with my patients relatively quickly that I can measure with these tests. I love tests that don't take a long time. I have 30 seconds. I'll spare 30 seconds for this test. But you guys know, how fast do those PT visits happen? I mean, even when they're 30 minutes, how fast do they go by? You blink and all of a sudden it's like, oh my God, I'm late. So I like the 6-minute walk test. I haven't done a 6-minute walk test. There's one person I've done a 6-minute walk test in the last few years because I wanted to be able to compare him to the norms that I wanted to. But for the most part, I'm doing 2-minute walk tests because I'm just comparing the persons themselves over again. These tests here, 5 reps and 30 seconds sit to stand, man, it's great. What I can also see, and this is part of the skill of us as therapists, I can also see, and I get to write this, 30 seconds sit to stand, result 8 reps. However, the first 6 reps were done in the first 15 seconds. And then the last 2 reps were on the final 15 seconds. So when I get to add that information, right, just 8 reps is good data, but incomplete. When I get to then describe, oh, they did actually 6 of these 8 reps in the first half, and they only did 2 in the second, we're actually measuring their fatigue. We're measuring how quickly they get tired. And it's really incredible to see that. Same thing for the 5 rep. Man, after 8 seconds, we're at 3 reps already. We're almost done. And all of a sudden, they just slow down, and it's just going to take another 30 seconds for them to get those last 2 reps out. It's really fascinating how you can see that. So yeah, the reps or the time is important for these. But man, if there's something else like that where we say, well, we can really start to see how this person declines quickly, that can be really important as well. There's a million different questionnaires. How many questionnaires did you guys see in your clinicals? I know photo a lot. What else did you guys see in your clinicals? Just photo for you guys? How about like DASH, disability of arm, shoulder, and hand, less lower extremity functional scale, McGill left, yeah, McGill pain questionnaire, anything else like that? Yep, and they get to write with or different, like this circles mean this type of pain, triangles mean that type of pain. Yeah. Any other questionnaires like that where you say, actually, here, you just fill out this stack of papers. It's probably on tablets now. You guys saw those in your rotations. So there's a bunch of those. What I love about those is we get patient data. We get the patient has to do it. So anytime, you know me, the less work I have to do, the better. So I like just hand a stack of paper and say, yeah, you do it. But we do get a lot of good information. There's a lot of different ones out there. They all have funny names. But we could do that for our patients. And after that, we get a bunch of numbers that come out of it, and we get to measure that over time too. So I really like questionnaires because it gives us different data, and it's a way to make their subjective information into a concrete number. So I really like that. So there's a bunch of them out there. I would never expect you to learn those, know about them. And if you see some questionnaire type on the licensure exam or on written exams, you're going to know, oh, okay, it's some sort of questionnaire, just like photo or LEFS or DASH or anything else like that. There's a million of them. Other observations could be the number of pillows or the degree of head positions when sleeping. This is actually, or sleeping in the recliner. This is something that I look at when I enter somebody's home a lot, is just how many pillows are on their bed that they're using with sleep, or if they're sleeping in the recliner. Also helpful for cardiac conditions for that. So we'll look at the cardiac sections later, but it has to do with just how hard is it to breathe when we're in supine. And if we need that head elevated, that's a sign. And there is a test where how many pillows do you sleep with, and actually it's probably embedded in those questionnaires. And there's grading systems for 1 pillow, 3 pillows, 5 pillows, sleep in a recliner. So that can be really important. Do you see it in the nursing home too, where they got the head of the beds all the way up as they're asleep? Yeah. Anyway. All right, I feel like we've been going pretty hard for a little bit. So let's take a little pause here. Let's take 10 minutes. We can fill up our waters and we'll come back and do some more stuff, okay? All right, so we're gonna go through a few disorders. We're gonna get some more hands-on work. Eventually, we'll take a lunch break. Somebody keep reminding me about that. We got a lot of other stuff to do today and a lot more hands-on stuff. I actually think pulmonary is more fun to treat because we get to do more things. Cardiac, it's a lot more complicated, but cardiac is basically exercise. Let's just get the heart going. Pulmonary, there's a lot of different things we can do. So it's a little bit more fun. So hopefully we'll get to some fun stuff in just a little bit. So general signs and symptoms of pulmonary disease: cough, dyspnea, cyanosis. What's cyanosis? Turning blue, usually at the lips and fingers. Chest pain, back pain, chest shape and reduced thoracic movement, and then pulmonary edema can happen as well. Others, atelectasis, partial lung collapse. I see atelectasis on licensure exam material all the time. So that's that. This section of the lung is not working. It's not getting airflow in and out. And then we'll figure out how to treat that shortly, actually. Bronchiolitis, pneumothorax. Pneumothorax is interesting because that's where air enters the chest wall. And actually, what happens is the pressure outside of the lungs is greater than pressure inside the lungs, which that's going to cause the lungs to collapse and not be able to expand. So you have to get that air out. And then pleural effusion is just fluid in the pleural cavity. So there's two main categories of lung diseases, either obstructive or restrictive. Obstructive, you can't get air out. So you have this gradual buildup, and talked about that anatomic dead space or residual volume. There's supposed to be a little bit of air left behind. Well, that little bit of air gets to be more and more and more and more and more. Now all of a sudden, that lung is filled with air that's not getting in and out. It's just taking up space. So that's the hallmark feature of obstructive diseases. Restrictive can't get air in. I think of restrictive as just have in my mind like a really, really tight jacket. Anybody put on like a really, really tight like wetsuit or something like that, and all of a sudden it just ribs can't expand. You can't breathe because you know that prom dress is so tight that you had to do this thing to get it back in, right? So so you know what I'm talking about. So you're so good to me. Thank you so much. So obstructive can't get air out, narrowed airway because of excess mucus or airway constriction like asthma. Increased airway resistance, which means air gets trapped in the lungs, which causes us to become overinflated. So when you talk about that chest appearance that we were talking about, those people, the classic term is that barrel chest. It's just their lungs and thorax is just so big, but they're not really doing their job, just holding in wasted air. Restrictive can't get air in, stiff lungs, chest walls, weak musculature. The term for it is compliance. So compliance means can this thorax, can it expand and then recoil? We need both to be able to breathe. We need the expansion to take air in, and then we need to have adequate recoil to then get air out. So I think you guys could see if we filled up that balloon, if it was a new balloon and we fill it up, and then it stretches a whole lot, then we let go of it and it shoots around the room because it has that recoil. But an aged balloon, something that's been worn a lot, you blow it up and sometimes it just loses that elasticity to be able to shoot across the room. I wish I brought in some of my kids' balloons, but so now let's see. We got a lot of things we can do. Let's cover a couple of other things there. So restrictive diseases, again, restrictive can't get air in. So anything that affects lung expansion, I think rib fractures for me is an easy one. broke my rib. I can't let it move. I try to breathe. I hold it still so it won't move, right? So that's that kind of restrictive. So scarring of the lung tissue can cause it, fibrotic changes, asbestos type changes. Obesity can, right? So now that extra tissue is restricting that thoracic expansion. Obstructive, a few major examples: asthma, that inflammatory response, bronchoconstriction causes the obstruction. COPD is the group of lung diseases. COPD is probably the most important ones. I mean, they're all important, but again, when I start looking at licensure exams, I see COPD and a whole heck of a lot. So COPD is just a group of lung diseases, although when I look at patients' charts, it's just COPD. It's just like reading back pain. Why is the back pain? I don't know. But so there's a few different subtypes. So emphysema and chronic bronchitis are the two main conditions we think of with COPD. But again, a lot of times I see patients that are just described as COPD, chronic obstructive pulmonary disease. So COPD, again, that group of conditions: increased airway resistance, difficulty with expiration, restrictive, decreased compliance. FEV1 greatly reduced in obstructive diseases due to overinflation of the lungs. Restrictive, the ratio could still be around 80%, so I can still get 80% of the air out. However, all of the lung volumes are decreased because I'm just not exchanging the right volume of air. So that's a good way to determine the difference between the two categories of lung diseases. So here's a nice chart talking about the differences between obstructive and restrictive diseases, and symptoms and other examples with that. So feel free to look at that. We're going to expand on some stuff. Volume loop just talks about how much air is moving per second. I don't want to get too bogged down in that. Nope, sorry, I stopped clicking that one. Sorry. So there's that chart of obstructive versus restrictive that I was talking about earlier. So a COPD condition to consider: chronic bronchitis. Chronic bronchitis is defined as a productive cough. Productive means we're getting mucus out. That's present for at least 3 months of the year for 2 or more consecutive years. 3 months of productive cough. I mean, we've all been sick at some point where, especially if it's a pneumonia or something like that, where that cough can linger. I know when I had COVID, I mean, the cough was just lingering forever, it felt like. Could you imagine? And forever for me was probably 4 weeks was probably what I was pulling my hair out for. Could you imagine 3 months of a productive cough? That is just an eternity. And then 2 consecutive years of it. So it is chronic inflammation of the bronchial tree, which will produce excessive secretions that are expirated, which is coughed up. Get it out. Main cause of chronic bronchitis is cigarette smoking. Cigarette smoking is something we're going to talk about a heck of a lot. But there are other environmental factors that can cause it as well. Not everybody that has chronic bronchitis is because of cigarette smoking, but sometimes it's someone else in the house is too, so that can be really tough. So productive cough, dyspnea, chest tightness, increased accessory muscles of respiration use, could lead to right heart failure, edema. FEV1 is reduced to 70% or less and reduced overall. So it is a progressive condition with repeat infections. I do this all the time. And the infections can be life-threatening. So one thing we'll talk about later is patient education and the importance of these vaccinations like flu vax and potentially COVID as well. There's a pneumonia vaccination too. So our patients with chronic bronchitis like this, we definitely should be advocating for, at the minimum, flu shot and pneumonia vaccination. I think the COVID is a little bit more controversial. I'm not sure we have enough data to know if people with chronic bronchitis, if it actually prevents illnesses or severity or not. That's the hope right now. I'm not sure we have enough data on that yet. But it is a progressive disease. But if we can make lifestyle changes, including exercise and quitting smoking, if that's part of their makeup, then they can reduce acute episodes. So they're always going to have some level of chronic bronchitis, but if we can reduce the frequency and severity of it, that would be a huge win. So medical interventions, smoking cessations, medications for bronchodilation, steroidal medication maybe, preventative vaccines like I talked about. For us, breathing exercise, airway clearance exercise, postural drainage, percussion, vibration, progressive exercise program. So there's a whole heck of a lot that we can do for these types of people. We're gonna do just a couple of things right now. Let's see, what do I want to do? What did I mean by posture? Oh no, that's that. All right. So I'm going to skip again down to slide. I have 86 on my list here, although I think I changed it. 85. Nope. Uh-oh. Oh, there we go. 87. Slide 87. So let's see. So pursed lip breathing exercise is a great exercise to help our patients get more air out. So unresisted inspiration followed by active oral expiration through a narrowed or pursed mouth opening. So the smaller the mouth opening increases the pressure in the lungs, which actually helps get more air out. Allows for better gas exchange. So I think, again, this is one of those COPD immediately teach pursed lip breathing. Like it's just one of those that it's direct. Somebody with osteoporosis, great. Balance exercise. It's just automatic. So whenever we have somebody with COPD, we should be teaching pursed lip breathing immediately. Now, I will say most people do this automatically. A lot of the stuff we're going to talk about for breathing, the person actually does automatically. We just have to cue them that this is a good thing and you can actually do this more often. So I don't typically have to, we'll talk about positions to relieve dyspnea. One of the positions to relieve dyspnea is forward leaning with your arms anchored. How many people said if we ran sprints, we'd do this, right? Forward leaning, arms anchored. We do it automatically. Some of our patients with COPD or other lung pathologies like using walkers, not because they have a balance problem, but because the position for their arms to be anchored to so they can help breathe better. So some of this stuff we don't have to teach to them. We just have to teach them that your body is doing what it's meant to do, and we can do this even more frequently. So I think the big thing to remember is almost like you're blowing out. When we talk about pursed lip breathing, sometimes we use the analogy of blowing out candles, so that can help. But even better, make the flame flicker, but don't extinguish it. And that helps keep the pressure in our lungs so that we can exhale more air over a longer duration. Okay, so what I think, this is so easy to do it individually, but I think some of the things that's hard to do is to teach it to somebody else. So what are the words I'm going to use? How am I going to phrase it? So go ahead and inhale however you want. A lot of our times our clinicians are cueing our patient to breathe through the nose. I don't think that's as important for this, but it can be. So normal breath in. And then as you breathe out, I want you to have a really narrow mouth and act like you're going to blow out a candle, but not all the way. Just make the flame. Do you guys feel that added pressure, that internal pressure more? Right. So again, if one of the hallmark signs of COPD is air doesn't get out, which makes this residual volume grow over years. Well, we got to get that residual volume back smaller and smaller and smaller. How the heck are we going to do that? This pursed lip breathing is the first one that we should be teaching. So not only when our patients have an episode of dyspnea, we can tell them, hey, remember that pursed lip breathing. Again, when they're having dyspnea, they probably do it all automatically. Has anybody ever seen somebody do that pursed lip breathing? Grandma, after we walk from the parking lot, we finally sit down at Applebee's and they're already doing it. Yeah, you've seen it. You've seen it. So again, a lot of times it's automatic, but we can cue our patients, no, do this all the time. We can do this all the time just to help prevent you from getting episodes of dyspnea. So what I want you to do, and this might feel a little funny because we already know it, but get one rep of educating a patient. So talk to your classmate as if they're a patient, because sometimes you guys have figured out like, well, I know what I want to say, but somehow my words aren't coming out right. So just get a rep of teaching someone pursed lip breathing, okay?
Wow. It's gonna be a long day.
After you're about to go out, so I want you to not fully blow out the plane. Just have it like a little bit, so it's a nice constant. So there's not that much. Wait, but you should do it all the time, to judge guys. Yeah. It's so What?
His grandpa was now, of course, they asked him, "Well, you want me to come over here and help with us?" That's great. I left it with the soda, you know, it was. Look, every time we go down that name, we were in like. You go through
All right, how did that go? Easy enough? So here's a little cartoon of chronic bronchitis, just to try to remember some of the hallmark features of it. A lot of times we lovingly refer to people with chronic bronchitis as blue bloaters. So the increased residual lung volume, again, that anatomical dead space, uh, creates a greater size. Also can create some residual edema and giving us that bloated appearance. Also, decreased oxygenation will cause that cyanotic appearance, that cyanosis. Typically, lips and fingers. You could probably see some digital clubbing too if it was chronic, which it typically is. Emphysema, typically over 45 years old, affects females slightly more than males. Main cause is smoking, but also genetics can play a role. So the walls of the alveoli are destroyed during the inflammation cycle. So there's decreased surface area for gas exchange. Walls of alveoli lose their elasticity, which limits their expansion and recoil. So not able to, air is unable to escape. Patients can attempt to increase their air intake, so that's with tachypnea. Also, we'll see a lot of accessory muscle use of respiration and have that barrel chest appearance as well. So can become life-threatening in the more advanced stages. It is also progressive conditions. Infections can also have serious complications. So again, we recommend, we can advocate for a lot of those prophylactic vaccinations. Oxygen supplementation is likely, potentially lung transplant, although that's pretty tough to come by from what I see. A lot of these chronic conditions, especially if you have a lot of comorbidities, your spot on that transplant list gets lower and lower. One of the guys I jiu-jitsu with, his girlfriend is a transplant nurse. So at the drop of a hat, she gets a phone call and you got to go to, she was in Texas for, I forget which organ, like she just, that's drop of a hat. So it's great because he actually moved up to Boston, but now he goes back to the gym whenever. And he goes, my girlfriend had to go save a kidney. And yeah, pretty cool. So anyway, also partial lung removal can help. So this one's a little weird. So if we've got all of our lungs, but there's one section of it that doesn't work well, if we would remove that one section, then all of the air we're taking in and out are remaining in the healthier sections of the lung. So it's a lot like pruning your plants. Cut off some of the dead pieces, then everything else gets to grow because of that, because we're not delivering energy and resources to this area of the lung or the plant to all of the energy can go to the good places. So that's an interesting approach. I had one guy, he had lung cancer and he had 2/3 of one of his lungs removed because of it. So it was pretty interesting. And he had a third of his clavicle removed, or maybe it was the whole thing. I think it was the whole clavicle. So yeah, tough to raise your arm up if you don't have a clavicle. Anyway. So some testing that we can do, obviously, strength and endurance testing, home assessment, energy conservation techniques. One of the things that we can try to do, there's our cartoon of emphysema, known as a pink puffer. Because they become pink because of the compensation, there can be an increase in ventilation, which give us that more pink appearance to the skin. No cyanosis, but thin appearance due to muscle wasting. So there's our side-by-side comparison. So one of the things that we could do for emphysema potentially is segmental breathing. Slide 85. So going down to slide 85. We'll do some segmental breathing. This will make a little bit more sense as we do some other stuff, but I like doing stuff now too. So segmental breathing is a way that we can cue our patients to try to force air to a section of the lung that's not working as well. When you guys go, it's actually a PNF technique. And when you guys do PTA 4 next semester, you'll look at different ways you could do that, reversals and inhibition techniques. You'll learn all of that sort of stuff. So this falls in line with that. So the easy way to think of it is push your ribs into my hands. So with our auscultation techniques where we're listening to all the section of the lung, if we find a section of the lungs where they have decreased lung sounds, we can try to get that person to force more air into that section of the lung with our tactile cues. So we're going to put our hands over our ribs. We're going to listen for where the problem is. Then, and sometimes we know where the problem is because of medical testing that was done outside of us. But we could also do it with our listening skills that we worked on earlier. So let's just say we found an area that we think they're not having a lot of gas exchange in. We put our hand over those ribs and we say, push your ribs into my hands. Because if the rib expansion is happening there, the lungs are expanding underneath of that, and the gas will start going into that direction. So it can be really, really helpful. Good indications: decreased lung volume, decreased chest wall compliance. Again, if we can see, this actually happens with a history of rib fracture. I broke my ribs 6 years ago. Well, when we really examine someone, especially without clothes on, so we can actually see, we might see one side of their ribs moving in and out normally, and the other side doesn't, just because of history of rib fractures 6 or 7 years ago. So this might be needed in absence of an actual lung condition. We just might find this with a history of rib fractures. So what I love about this, there's no contraindications or precautions unless the person needs to be in a position that is contraindicated for them. So if they have a stage 4 pressure ulcer on their sacrum, all right, well, I don't want to put them in supine because that's the position like that for this person. But as far as the technique itself, there's no precautions for it, which is great. So we can do it in sitting position if we have basal bottom of the lungs atelectasis, side lying with the affected lung uppermost, or in a postural drainage position if needed. We'll look at postural drainage in a little while. So all we're going to do is therapist applies firm pressure at the end of exhalation to the patient's chest wall, overlapping the area that we want to be expanded. And then we cue our patients, breathe in deeply and expand your ribs underneath my hands, right? That cue, push your ribs into my hands. And then the therapist reduces hand pressure during inhalation. So could I have you side lying up here for me, Alan? Yeah, sure. All right, good. You good enough like that? So let's say I did my listening techniques and I said, okay, left lateral lungs, I did not hear a lot. So what I'm going to then do is I'm going to say, do you feel my hand? I'm going to put my hand right over whatever I think that section, either with my visual inspection or my auditory inspection of his lungs. Either I'm hearing decreased breath sounds over here, or when I look at you, this section of the ribs just aren't moving like the rest. So I'm going to put my hand over that area of dysfunction. And I'm going to say, do you feel my hand here? Good. So then what do I have to do? He takes a normal exhale, and I have firm pressure. So breathe out all the way. And now as you breathe in, push your ribs into my hand. And as he breathes in, I'm going to lighten up my pressure. So, because I don't want to restrict that movement. This is a tactile cue. I'm going to be firm at first so he knows exactly where to do it. I'm going to say, okay, after your normal exhale, breathe in hard, but push into my hand. Push your ribs into my hand. These ribs. That's it. Nice job. Nice job. And we'll do the same here, right here. Good job. Good job. Good job. One more big one. All right, and that's just how we're trying to cue, and it just gives that tactile cue. We're trying to improve that proprioception, that tactile cue to get whatever section is a problem. So let's try a few versions of these. Let's try some sitting. Let's try some side lying. Let's actually try some prone as well. Let's just try a couple of different. Try an anterior, try a posterior, try a lateral. Let's try a few different positions. When we learn postural drainage, then we're going to add some postural drainage positions again. But for now, just do something in seated, something in supine, something in lateral, side lying, and something in posterior, okay?
Put on.
All right, how did that go? Easy enough? Did anybody feel as you're the patient, like, and then even as a therapist, like, oh yeah, this section is able to change? Did anybody notice that as the therapist, that yes, this cueing is working? How about as a patient? Were you able to feel, oh yeah, I can direct those ribs to expand more? Did anybody feel that? Pretty incredible, right? So again, for some of our patients, that can be really, really helpful, especially for the variety of restrictive lung diseases that we have. I'll also just make a quick mention of restrictive lung diseases is, where were we?
Just giving you a time warning, it's 11:24.
Excellent, thank you. Posture, working on posture. Anytime our patients have breathing issues, working on posture is definitely something that we should be incorporating into it. I think especially for our more restrictive pathologies, but anytime we have a patient, we should be doing more for their posture.
As well.
Sure, sure. All right, so that's a good overview of obstructive versus restrictive. There's our side-by-side comparison there. So some other pathologies: asthma, acute inflammation of the bronchioles, reversible. Obstructive category: pneumonia is inflammation of the alveoli due to bacteria. I think we've talked about those awful lot. Cystic fibrosis, I think we've talked about a decent amount in patho. I will say, so one, it's genetic condition, excess mucus production, and high levels of sweat. And usually kids get to be found this out because everybody's kissing kids and they say this baby tastes salty, which is a weird sentence, like their baby tastes salty. But that's typically how one of the ways that we start to uncover this. Median life expectancy, I actually think this is a little low, 37. I think we're above 40 now. I think I could be wrong on that. And I will say, when I was in grad school, it was over 30. Like that 30-year mark was what I was taught. So, and before then, it was in the 20s. So the medical world has done an amazing job doubling the life expectancy for someone who has cystic fibrosis. And a lot of reasons for that is because one, medications are better, but two, ability to help these mucus secretions get out and not stay in the lungs is much improved. So we'll look at a lot of different things: postural drainage, airway clearance techniques. We'll look at those a lot later after lunch. So here's some categories of diagnoses and the risk factors. What other things would happen with that? Other restrictive pathologies include lung cancer, pulmonary infarction due to pulmonary embolism. So so again, the lungs need blood supply. If the lungs don't get blood supply, that tissue will die, just like a heart attack or anything else. So if a pulmonary embolism hits the lungs, that tissue would die. That would be the pulmonary infarction, just like myocardial infarction. It's the heart attack of the lungs. So just the tissue dies, which means that tissue can no longer expand and recoil. It's dead tissue now. I had one patient have a pulmonary embolism. It was before he had a knee replacement. He was staying at his sister's house, which happened to be right across the street from the hospital. and he had a pulmonary. It was before I saw him on day one, and he said it was an elephant sitting on his chest. He said that amount of pain. He thought there was a 6-ton elephant sitting on his chest, and he was told that if he wasn't staying at his sister's, which was right across the street from the hospital, he wouldn't have made it. It was pretty unbelievable. So anyway, tuberculosis, you know how much I love talking about tuberculosis. So that's another restrictive pathology we might come across. A bunch of other ones that we could look at. ARDS, acute respiratory distress syndrome, rapid lung failure due to pneumonia, sepsis, near drowning, fatality around 40 to 70%, which is really, really incredible. But artificial ventilation is likely needed. Some different surgeries that the person might have to have. Pneumectomy, which is removal of a whole lung. Lobectomy, removal of a lung lobe. Chest tubes for pneumothorax to drain that air, and any other types of fluid that might be in the way. So just like with catheters and collection pads of catheters, make sure those are lower because those are gravity-fed systems. So don't throw them up in the air. Tracheotomy, tracheal fluid placed directly into trachea. Lung transplants. I'm going to quickly go through some medications. Medications can be really important. I'll say the two main categories when I think of lung diseases, there's a few other ones, but the two main categories of medications I think of is either get mucus out, that's one of the problems, or improve dilation of the airways. Like those are the two main hallmarks of whatever these conditions are. If these airways are narrow, expand them. Or if these airways are narrow because of mucus, get rid of the mucus. So those are the two main categories if we could oversimplify things. There are others, including antihistamines, which, examples, Benadryl, Claritin. So those are to try to decrease the inflammatory response. Anti-inflammatory medications, so just there's a bunch of different ones, but trying to reduce bronchoconstriction by inhibiting that ability. Bronchodilators is the other one that I was just talking about. So relieves bronchospasms by smooth muscle relaxation. So albuterol is probably the most common one of that. There are some others. What I will tell that's important for us if we see our patients who have lung diseases, asthma is an easy one for these bronchodilators. One, take them before PT. And then two, let's make sure we have them on hand because sometimes if we can remember the triggers for asthmatic attacks could be as simple as temperature changes. So being in this warm room and then stepping outside on the first cold day, that could be enough to trigger an asthmatic reaction. So make sure we have them on hand for therapy sessions, I think is the big safety thing we've got to make sure we do. There can be some cardiac or vision abnormalities that indicate toxicity, which means we need to alert the PT right away. Expectorant agents. So Mucinex is probably the most common one that we could see for that. So this helps loosen mucus so we can get them out, so we can clear secretions. So some side effects might include GI distress and drowsiness. The things that we can do for our patients is the timing of taking these medications versus the timing of PT. If one of our goals is to help get rid of mucus, and we've got a bunch of techniques we're going to be able to show you after lunch for that. I wish I planned this better. When I was planning the lessons today, I forgot about lunch. So I probably should have been doing some of this stuff before we filled our bellies, but we'll do the best we can. We'll make sure we have our trash buckets around somewhere. So the big thing though is if my patient's taking this medication at 8 a.m., I probably want to have my PT at 9. I want to use this medication to my advantage. So being able to time that, and in the hospital type setting and the skilled nursing facility type setting, that's usually a little bit easier to do. In the home or outpatient settings, it's a little bit tougher to do, but we can work with our patients on what time do you take these, and then what time can I come, and what can be realistic for both of us to work with one another. Um, Mucolytic agents decrease the viscosity of mucus and secretion, which makes them easier to clear, usually administered by a nebulizer. That's that breathing machine that has a little steam and vapor on it. So those are pretty nice. So side effects, increased inflammation of the airway, chest pain. But again, the thing for us, one, if we can instruct on proper use of the nebulizer, but also two, let's time our treatment along with these medications so that we can use them. Other medications and other interventions you might see: antibiotics, corticosteroids, vaccinations I've mentioned a few times, different humidifications, nebulizers, spacers for kids are often good ideas too. So, do we have any questions on it? We covered a lot so far this morning. Do we have any questions on anything we've covered so far? I think a lot of it was review, and with a handful of new things. I think what was new? The auscultation was new. Pursed lip breathing, segmental breathing was new. Dyspnea scale was new. Diaphragmatic breathing was something that's technically new, but not abstract. Anything on those that we're having questions about? All right, so we've got what, 30 minutes? So is it 30-minute break? Is that where we are? Okay, so 5 past, we'll get back and we'll do some other PT related stuff, okay? You guys doing great so far today. All right, so the next phase we're going to talk about, by the way, I think I forgot to mention this. Cardiopulmonary is the third biggest section on the licensure exam. So a lot of this material is crucial for your licensure exam. Not quite 20% of the exam has to do with cardiopulmonary. So really, really important stuff that we're covering today and the rest of the next week. So we'll talk about these next PT interventions. A whole bunch of them. Some of them are nice little devices. Other things are things we can do. So the first thing we can do is exercise, right? Exercise should always be one of the first things that we think of. So pulmonary rehab exercise consists of a check-in, which we take vitals and general patient assessment, a warm-up, exercise prescribed intensity, then a cool-down period. There's a variety of ways to prescribe that exercise intensity. Again, I think the somewhat hard on the RPE is just a simple way to do it. We could also do somewhat hard on the the rating of dyspnea scale. If we had VO2 max, we could prescribe it exactly from the VO2 max. So just like with strength training, if we had our 1 rep max test done, we could be really precise on our strengthening prescription. But can we get really darn close to a good exercise prescription without the formal 1 rep max test? Yeah. We could do it with MMT scores. We could do a 10 rep max test, or we could do it just with the Borg scale. We want this load to be somewhat hard. What do you think right now on the scale of 0 to 10? Too easy. Great. Add another couple of pounds, right? So we can do that with our strength training. Same thing for VO2 max. VO2 max, that's where the patient has to breathe in that tube and go through a strenuous exercise test to actually measure the volumes with. It is, Holly, you said you did it too, Cam, exercise stress. Tell me about your experience there. Yeah. Yep.
And there's wires everywhere, and I sweat before I was even like halfway through.
Yeah.
Dying.
And you got to your max heart rate and your true anatomical max heart rate, not estimated.
Yeah.
How fun is that to be at your max heart rate? I mean, it is absolutely one of the most brutal things you could do. I mean, those exercise stress tests, and the formal way to do it, there's other ways to do submax exercise stress testing. But we're going to keep going until you collapse. until you physically cannot go anymore. That is not a fun level of exertion for anybody. Never mind somebody who's got chronic bronchitis, emphysema, cystic fibrosis, whatever else it might be, any of these disorders we're talking about. So I think looking at VO2 max is a nice thing for research purposes, but I think clinically we just don't have a lot of patients measuring their VO2 max. It just doesn't happen all that often. And I think that's okay because I think I can do a pretty darn good job with just RPE or the dyspnea scales. But if we did have VO2 max, a moderate intensity would be 40 to 60% of VO2 max, vigorous over 65%. We could do it as percent heart rate max as well. 65 to 85% of heart rate max. How do we calculate heart rate max? 220 minus your age. Thank you very much. So we could do just with heart rate max, VO2 max. Again, it's a nice thing for research, but it's probably not going to, we're not going to see it clinically. Heart rate max, easy. Rating of perceived dyspnea or rating of perceived exertion are both available to us. 3 out of 10 on the dyspnea scale is approximately 50% VO2 max. 5 to 6 out of 10 is approximately 80% of VO2 max. RPE 12 out of 20 is approximately 40%, and then 13, 50%, and then 17 out of 20 is around 90%. So those are nice ways to get approximations for it. And again, I think in general, getting to that somewhat hard and sustaining that is all our patients really need. I think that's a really nice, simple way to go about it. 20 to 30-minute sessions is recommended, 3 to 5 sessions a week. We can do multiple daily sessions if 20 to 30 minutes isn't tolerated. The minimum is 10 minutes. So if we wanted to do 3 10-minute bouts, that's less than 10 minutes, we're not getting that aerobic capacity stressed enough. But it can be beneficial, at least 10 minutes. 6 to 12 weeks is the general length. However, longer than 12 weeks is shown to have greater and more sustained benefits, which is great for us. Now, one thing, I went to the physical therapy conference, I think it was last year when you guys were at class. Gotta click that, So HIIT training was all over the place with this conference. And that happens, sometimes research comes in waves. When the Nintendo Wii first came out in the early 2000s, there was a bunch of research on Wii gaming for balance, and it was pretty great. And right now with VR, now it's all headset VR. It's the same research, just a new tool. So HIIT training I could not get away from it at that conference. So high intensity interval training is generally preferred compared to continuous exercise for patients with chronic lung disease due to superior effect in improving exercise capacity and decreasing exercise-induced dyspnea. So in your textbook, again, O'Sullivan is that big. Anybody carry that book around with them? So over the last month and a half, knowing that I've needed to be teaching this, I've been carrying that book around almost every single day. So yeah, it's heavy. That book is heavy. Holy cow. But if you look at your textbook, there's a lot of different studies in there with their prescriptions. What were the exercise prescriptions and what was the outcomes of that? So you can glance at that if you want. Now, while HIIT training is generally superior than continuous training for all of the effects that we would want to see, continuous training is generally more preferred for patient adherence. So this is where the art versus the science comes to collide with one another. HIIT training gives us better lung volumes and better functioning of the lungs. However, continuous training can give us benefits of the lungs, but also improves patient compliance. And you guys, as the artists that you have become and will continue to become, are going to have to figure out for your patients what's going to be best for them. And I think I think that's probably true. Holly, you probably see that with your personal training clients, where some clients can do HIIT training and will love it, and others will not come back next week if that's what we do with them, right? And and that's your skill as the artist of the personal trainer, is to be able to figure that out, and that's what we've got to do with our patients as well. But I think for the textbooks, we have to be aware that HIIT training is preferred. So when our textbook, all the studies, the problem with HIIT training right now is there's a variety of definitions of what constitutes HIIT training. High intensity interval training. So high intensity makes it really, really hard. Interval means we have periods of really hard versus either periods of easy or complete rest. So that's what the interval is. Spike in difficult exercise followed by a decrease in exercise intensity, either to a relaxing pace or to complete rest. It depends. So I just put two different examples out here. This first research study did 4 rounds of 4-minute intervals at 90 to 95% heart rate max. So that's 4 minutes at 90% heart rate. Holy cow, that is tough. Followed by 3 minutes at 50% heart rate max. So that's it. 4 rounds of that. So 7 minutes per round and 4 rounds of that, and then we're out of there. So not bad. This other one did 10 intervals of 30 seconds of strenuous exercise followed by 60 seconds rest for a total of 16 minutes of total exercise. So again, those are two really different protocols. 4 minutes of high level versus 10 seconds of high level. Those are really, really different. So what I will tell you is I think the research at HIIT training and what duration of high intensity versus duration of rest, and what does that high intensity definition mean, what percent of heart rate max, I think that research is going to continue to grow over the next half decade and maybe even more. So make sure you keep an eye out for that to give our patients exact exercise prescription. But I will say, for me, I can get my patients doing 30 seconds of exercise. That's that, going back to that 30-second sit to stand test. I like doing things in 30-second increments. It's just, hey, we only got 30 seconds. You ready to do this? Go. I think I can get my patients to do that, even the ones that don't want to. 4 minutes of that, man, I'm starting to scratch my head and go, Tino, I saw your eyes roll up when we read that 4 minutes at 90%. That's tough, right? That's what a great way to put it. Putting in some serious work. I don't know if I could get my patients to do that.
Sports patient, maybe.
Sure.
Average person.
Yeah, and I'd have to look at this, but these were physical therapy patients. These are patients with COPD they did that with. So yeah, pretty interesting. Now, what I will caution all of us, because we're going to talk about HIIT training in cardiac as well, I think. I haven't finished that one yet, so got a long weekend ahead of me. When I first started learning about HIIT training with our cardiopulmonary patients, my first reaction was, no way. And then I started thinking about it. I do HIIT training with my patients all the time. It just looks different. My HIIT training for that patient who can't walk to that door and needs 2 rest breaks, that is HIIT training for that patient. Walking to that door and needing 2 rest breaks to get there, that is HIIT training. And if I were to monitor her heart rate, her rating of dyspnea scale, yeah, before she needs to sit down, her rating of dyspnea scale is to 8 or 9 out of 10. By definition, that's our high intensity. And it's going to take her 30 seconds to get halfway. Well, she's going to sit down and take a rest. So I think when we apply the term HIIT training, and it's like, well, that's what we do. That's what I do all the time. We're going to exercise until my patient can't breathe anymore. Then we're going to sit down and breathe for a while. Let's not overcomplicate things. But what I do want to just point out, when we talk about exercise first with our patients, I think sometimes in the PT world we get so scared. And we get scared for good reasons, because we want to make sure we keep our patients safe. But we also get scared of patients' reactions. They're going to complain the next day. They're going to complain during this. I don't want to how many patients when you were on clinicals goes, oh, that exercise was too hard last time. You got to do back off. Like it happens all the time, right? So, and I think that's one of the traps in the physical therapy world is we listen to our patients too much. Like, and again, art versus science, we need heavy intensity to get better. The art is how do we get our patients to comply with that higher intensity? And that's where you guys get to be your own experts and artists of getting that. But I want to highlight our patient with advanced COPD, chronic bronchitis, emphysema, cystic fibrosis. There's no reason that we can't monitor carefully, but also have them exercise at 90% heart rate max. There's no reason we can't get them there. Now, what the exercise that takes to get them up to that level sometimes is so very low. You know, what would it take to get to Reed to get to his 90% heart rate max? Sprints, burpees with a weighted vest, you know, like something extremely strenuous. For these patients, as simple as walking to the door could be it. Sit to stand for 30 seconds could be that high intensity exercise looking for them. So it's the same principles just applied into our patients. So don't be afraid to challenge your patients. And if your patients are afraid, this can happen. Our patients are afraid to get that worked up because anybody ever been not able to breathe? It's so scary. So getting our patients to work that because of the fear of that I don't like that feeling of breathlessness. Sometimes again, that's the artist that we have to become. But let's not be too afraid to push our patients. We definitely can. Positions to relieve dyspnea. Again, this is something our patients do automatically, but we can encourage them. And so our forward leaning, especially with the arms positioned, with the arms anchored. So we can see 3 different examples here, just leaning on our laps, sitting in a chair, leaning on a table, or leaning against a handrail. That picture got a little cut off there. So optimizes length tension of relationship with the diaphragm, allows pec minor, major, serratus, and other muscles to assist in rib expansion. Anybody ever see someone with accessory muscle breathing with their scalenes and upper traps? Anybody see that? It's remarkable to see someone breathing like that. It's really something to behold. But anyway, so that forward leaning helps anchor the diaphragmatic length tension relationship, but also just anchoring those arms down to allow those accessory muscles to assist in rib expansion. Really important. Here's reverse Trendelenburg. That's that person on the stretcher. What I will say is important for reverse Trendelenburg is we have to have a foot plate there, or else they're just going to slide right out of bed, which now we've got different problems on our hand. Now they can't breathe and they're on the ground. We got 2 problems now. Get a pillow. Pillow and some oxygen and back out of the room and hand in your badge. So reverse Trendelenburg is supine with the head above the trunk and lower extremities. Trendelenburg is the opposite, so the head is lower. So this decreases the weight of, there's a typo, of abdominal contents on the diaphragm, thus reduces the resistance of breathing. And then we also have this semi-Fowler position here, Fowler and semi-Fowler. Semi-Fowler is supine with head of the bed elevated to 45 degrees and then knees under pillows, or with the legs of the bed flexed like that. So that can be really helpful to a position to relieve dyspnea. And actually, when we talked about sleeping with the head, our patients sleep in the semi-Fowler position. Our patients who have trouble breathing sleep in the semi-Fowler position. If anybody has a loved one that has cardiorespiratory issues, I bet you if we peeked in their bedroom, they've got so many pillows built up, or they've got a mechanical bed where they're sleeping in this semi-Fowler position. Same thing, recliners, semi-Fowler position. So that one I see a heck of a lot. Talk about posture all the time. Anytime we have pulmonary especially, but man, we've all gone through the exercise where we try to, have terrible posture and breathe versus really good posture and breathe. Poor posture limits thoracic expansion. So if we improve posture, we can improve thoracic expansion, which then helps the lungs take in more air. So if we can improve on somebody's posture, man, we can improve their lung function and their physical function as a result of that really, really well. General strength training, can we follow the typical strength training guidelines? However, we want to be really focused on prevention of that Valsalva maneuver. Especially for patients with COPD that are already holding on to too much air to begin with. So now if they're doing exertion with holding their breath, they're going to hold even more air in. So focusing on that. Now this thing here is an inspiratory muscle trainer. That picture kind of got caught off a little bit funny. So this thing, we can breathe into this device and it creates resistance of getting air in and out. So what this is doing is it's because we're adding resistance, we're training those muscles of inspiration to get stronger and stronger. I saw it for a little while. It was popular for a brief period of time. Anybody ever see those masks people run with try to, and they say, oh, I'm making this better. It's similar to that. So I actually have a patient right now. Oh, this is a heartbreaking patient. But she has a really rare progressive neuromuscular disease. And one of the things she's doing is using one of these all the time to hopefully preserve her life for as long as she can. She's 48, 2 kids. It's just awful, awful, awful. So what we could do, just like we can do with our regular aerobic exercise. So these, I'm not sure about this exact picture, but hers, you just turn a dial to adjust the intensity. So how much resistance is going to be in that airway as you breathe in and out. We could do continuous training, just like any aerobic or exercise training. We could do continuous training, 10% of what was PI max? It was the inspiratory pressure. We could do that for 20 to 30 minutes, progressively going up to 60%. Or we could do interval training. So just like HIIT training, 2 to 3 minutes with rest breaks of 1 to 2. Again, actually, I was looking at this woman's inspiratory muscle trainer, and in the instructions, it had a dyspnea scale, and it said you want to be in the somewhat hard. It was all color coded for it. So again, going back to that dyspnea scale or RPE scale, we can use those for devices like this inspiratory muscle trainer. If you want to do high intensity, great. Let's crank it up. Let's get to that 8 to 9 out of 10 dyspnea scale. Or if we want to do more continuous, we get to drop it down to the 2 to 3, 4 range on that dyspnea scale or RPE. So either way, we could do it. Incentive spirometer is another device that we can use, and I think these are given to every single patient in the hospital. Skilled nurses, you see them with every patient, or just a lot of them? Not all of them. So what these are, they have little tubes here. There's a few different versions of them. There's these little smiley faces. Breathe harder. Don't breathe too hard. We want to get it right in the middle. And then this also gets to say how much volume approximately are you pushing through. So it's used to improve sustained maximal inspiration. Held for 3 seconds or more before exhalation. So the visual feedback of this ball going up and down, and if you went back to the incentive spirometer, the electronic spirometer, there's another picture with 3 little balls in a tube. So that's another version of the same thing, but another version of it. So this provides that visual feedback to encourage there's another typo, ling. What's a ling breath? I don't know. Slow, deep inhalations. We tell our patients do this 5 to 10 times every hour. Holy cow, that's a lot. It's all day long, doing 10 different times every hour. but it's really good to prevent atelectasis. Or if the patient has it, it's a good way to, so it's either to prevent that partial lung collapse or it's to treat that partial lung collapse. So good for patients with moderate to severe COPD as well. All right, let's go through this stuff real quick and then we'll get some hands-on stuff. So secretion removal, we talked about the importance of secretion removal for a lot of our patients. Cystic fibrosis, when you guys hear cystic fibrosis, your first thought should be secretion removal. Chronic bronchitis, it's one of the first three thoughts on chronic bronchitis. So anything that has a pneumonia, boom, secretion removal. So there's a few conditions that you automatically have to do. There's different ways that we're going to assist with that, but these are some devices that our patients could use. So there's the flutter. That's what this one is. So these little balls are inside this device. And what that's going to do as we breathe in, that's going to create a vibration effect to that air. And that vibration effect is going to go into our lungs and vibrate all of our airways, which can help loosen mucus. And then if the mucus is loose, we can start to get it out. The acapella, which is the middle ones here. Same thing, it's just a slightly different unit, but same thing, airway oscillation, vibrate that airway, vibrate the air that's going to the airway, and if that vibration moves mucus, then we're going to be happy. And then here down at the bottom picture, there's the vest system. High frequency chest compression, we put that on and it shakes the patient a whole bunch, just like the beds at a cheap motel. Like we put the coins in and it goes. So that's pretty fun. I had a patient, he's got COPD, he's getting worse all the time. I'll see him twice a year for his entire life. In a bad year, I'll see him 3 or 4 times. So he had a recent exacerbation and they used the vest system in the hospital. And when the family got home, they said, where can we get a vest? What can we do with it? They're really expensive, but what we were able to do is we were able to say, listen, I know you like that stuff and we know this condition's not going away anytime soon. So if you want to save some money and get one, I'd go ahead. Or for $30, you can get one of these devices and it's okay. And so that's one thing that we can do and we can encourage our patients for. Now, for our patients with cystic fibrosis, I'm seeing more and more of these vest systems are just given to the patient all the time, and they do it every single day. This is part of their, and one of the reasons why our life expectancy with cystic fibrosis is improved from the early to mid 20s to over 40 now is because of use of things like this on a daily. So other things that we can do to assist in secretion removal, postural drainage, percussion, shaking, and other airway clearance exercises that we can do. So postural drainage is using patient's position to use gravity to assist in removal of excessive secretions. So first we're going to do is we're going to listen to the lungs just like we started with today. We're going to identify the areas that we hear either those crackles or diminished lung sounds. Those are the areas that are fluid, or if they're whispering and we can hear them still, again, that means that section of the lung is full of fluid that's transmitting the sound. So then what we're going to do, once we identify the section, the lobe, or the section of the lung, we're going to place that so the lung segment is perpendicular to the ground. So if I'm in, let's just think about this for a little bit. If I'm in reverse Trendelenburg, if I'm in Trendelenburg position, where my feet are higher than my head, if I had a lot of mucus in my lungs, where would gravity pull that mucus to and it would settle in? Probably the upper lobes, right? And if I'm in supine with this Trendelenburg position, again, Trendelenburg is just the feet are higher. So if I'm in supine with my feet above my head, be more specific than just the upper. So the upper, yes, but then be more specific. if I'm a supine, it's probably posterior as well, right? So posterior upper lobes would get filled up with that mucus. How would I drain that? I would have my patient sitting upright or maybe even just pitched a little slightly into prone. That way we're going to put those loads perpendicular to gravity. Does that make sense? Do you need a visual of that, or does that make sense so far? Makes sense? So who can tell me if I've got left lateral lung crackles? What position would you put me in? So left lateral lung, you hear the crackles. Which side lying? So right side lying, good. Anything else? So then depending on, so I only said what, left lateral. So if it's left lateral, but more of the superior aspect, then I'd want to have my head pitched up a little bit more. If it was more lower lobe lateral, then I would have to have my feet pitched up a lot, right? Does that make sense to everybody? So it's just using gravity, just like if someone sprains their ankle, what would you do? Elevate the feet, right? So same exact principles. We're just using gravity to assist us in moving secretions. So there are standard precautions. Variations should be used for specific patients' needs. As long as you can understand, I'm going to listen to your lungs, and the sections I feel like aren't doing well, I'm going to put those against gravity. And then that's it. So there's plenty of patient-specific, we'll look at some specific examples, but there's plenty of patient tweaking that we're going to have to do with this. So some precautions: congestive heart failure, hypertension, pulmonary edema, shortness of breath is made worse by positioning, obesity, abdominal distension, nausea, recent food consumption. This is my mistake for doing this after lunch. Different bypass grafts, OA, recent rib fractures, other conditions that would make it appropriate, the appropriate positions uncomfortable. Well, if I have a stage 3 or 4 greater trochanter pressure sore, I'm probably not going to go inside lying on that, even though I'd like to get the lungs clear. Like that's going to be something we have to really try to figure out. Can I actually do this safely with the person? So we're going to, what the heck happened there? Learn all of this. How do we do that? All right. So here's the textbook, the picture from your textbook. If anybody brought their books with them, at page 409. But here's what I want to try. I want to try these positions real quick. So if we have the upper lobes, again, we're going to be on more just sitting upright. Upper lobes, but more on the posterior side. We're going to be a little bit more pitched forward. Upper lobes anterior. We're going to, again, putting them perpendicular to gravity. So now we're going to be supine like that. Right middle lobe, left upper lobe, lower lobes, the lateral and basal, posterior basal, and the superior. So what I want to go through now, we've got 9 different positions depending on the lung, the lobes of the lung that the problem is at. And I just want to try getting into those positions. We've got a bunch of pillows. The heads do come up somehow. I forget how they do it. But let's try to get into as many of these positions that we possibly can for now. And then when we go to see our percussion techniques, we'll use both of them, okay? All right, we're going to get a little bit more time with these positions in just a little bit. So I think it's really important to understand the basic positions like that are in our textbook. I also think it's really important to understand that we want to be patient specific, and we're going to be able to be patient specific depending on our assessment on listening to their lungs. That is what's going to help us say, it's this section of the lung. Let me put this person in a position where I can use gravity. So, you know, it's nice to know the textbook, but the textbook sometimes doesn't apply to our patients. And what I also think is a flaw in how we teach, and then you learn, and then so oftentimes we're not going to know what section of the lobes are in need of this postural drainage. That is on us to figure out. Yeah, a patient can have an X-ray, and on the X-ray findings, we could say, oh, this section of the lungs, great. The radiologist told me that. That's great if we have that information. But man, if they got an X-ray on Tuesday and there was one section of the lobe that was clogged up, well, if they've been in left side lying for the last 2 days and they haven't gotten out of bed, all right, well, just because I know what position is, I know the left lung is the thing that's going to be clogged, just because gravity is the thing that's pulling all that mucus into that side anyway. So it can change quickly. So even though sometimes our patients will have medical testing that will describe areas, it can change quickly depending on the positions they were in for the last, just a day, just a half a day could be a difference. So it's really up to us. That first skill that we learned today, maybe it wasn't the first one, but the listening of the different sections of the lungs is going to be the thing that clues you in on where to go. Now, I will say, I think also on written exam, whether it's for this class or for your licensure exam, the questions are going to be formatted either right lung or left lung or bilateral. They're going to be phrased anterior, lateral, or posterior sections of the lung. And they're also going to say at upper, middle, or lower sections of the lung. The right lung is the left lung doesn't have a middle lobe. It only has two lobes, the right one does. But when we talk about segments of the lung, we could be talking about the middle segment. So middle lobe is only the right lung, but both right and left lung have middle segments, if that makes sense. That's a weird terminology thing that I wanted to make sure we understood. But you can play throw these into ChatGPT and say, I need quiz questions. Give me a quiz on right lung versus left lung versus bilateral lungs, anterior versus lateral versus posterior, upper, middle versus lower. Give me a bunch of exam questions on if I can get this postural drainage right. So let's try that. So if we had right posterior lower lobe. I'll also say, if you're having trouble with verbiage, do we have sticky notes or something like that, Tony, or tape or anything along those lines? Oh, whatever. Yeah, perfect. So thank you. I'll do this one. So what did I say? What did I say? Right posterior lower?
Yes.
Something like that, right? Sorry, you can't see read. Okay. So again, for some of you that are having trouble, especially after lunch, the afternoon crash, or some people woke up at 3 in the morning and never started paying attention in the first place. So if you're in that category, sometimes I know when we're wrapping our verbiage around things, sometimes it's so hard to get your brain working on the verbiage, where that visual cue of just slap a sticky note on somebody to talk about it. All right, so what position would we put Reed in to use postural drainage, to use gravity to drain that right posterior lower lobe? Prone, good. Makes so it's posterior. So prone better than supine. But say more. But probably biased towards a little bit of sideline. So maybe we use one of those half turn positions. So probably half turn and prone, something along those lines. Does that make sense? You know what I'm talking about there? So half turn to prone.
And then his feet raised up.
But which side is the upper side? Which side is the lower side when we're talking about half turn to prone? So the right is the upper side. Okay. All right. So that makes sense. So then what else? feet elevated. So the whole, like if we could tilt these whole beds like that. Yeah. So tilting the whole bed. Anything else? So it would be something like this. Reed, do you mind jumping over here for me? So let's see. We want,
This way.
I want your feet raised. Yes. Yeah. You want to be down that way. Is that where you want to be? Where do you want to be, Reed? All right. So we want, all right, let's face the class though.
Yeah.
So let's get,
Let me know when down. Head this way. Raise,
yes,
yes,
yes. Sorry. Feet that way. And I didn't do it so you would face the class. So, so again, I'd probably try to get under his hips a little bit more if we could, you know, something like that. There we go. Does that start to make sense? And we're probably a little bit more like that if we could. So just pitch that way a little bit. Does that make sense? Right. So now we've got, are we perpendicular to gravity with this? Yeah, I think that's pretty good, right? Thank you, Reed. I appreciate it. So I think some of the skills you guys have to have is, yeah, get the textbook knowledge, yes, but we also have to be specific to the patient. And then I think when we go to written exams, either for this class or your licensure exam, this is how they're going to break it down. And you just have to say, okay, well, if it's these three factors, I've just got to figure out how to get that to be the highest point. And if you can do that, you're going to get every single question on postural drainage right. And you're also going to be able to position your patient in the most appropriate position. So make sure you can juggle these three different parameters for that. Does that make sense? All right. Is that a simple way to think of it? So I think sometimes there are certain things that like you have to know the specifics on. Step 1, step 2, step 3. This exact position is good for that. And sometimes you just got to know the concepts. And I think this is one where if you learn the concepts really, really well, and if the concepts make sense to you, you're going to get it right. Okay. Any questions on postural drainage at all? Okay. So let's do this. Let's take, I want to do some hands-on techniques next. We're going to use our hands-on techniques in combination with our postural drainage positions as well. So we're going to get a lot more reps of that. But let's take 10 minutes and then we'll finish up. That'll be the last break of the day. We'll finish up there on out, okay? All right, so we've got a handful more things to do and not a ton of time to get there. Some of it's going to be fairly quick, but we got plenty of stuff to do. So the next things we can do, techniques for airway clearance, manual techniques. So the first one, percussion, is actually, we started with this in massage. Remember the percussion with the cupping techniques? So that's what the technique is. So we're not doing the wrapping or the hacking, it's the cupping one. So we really want to make sure we have cupped hands, so domes on the hands, and we want to have, we're not going to be rigid with it, right? We're going to be able to be bouncing off of our patient's thorax as we're doing it. 3 to 5 minutes over each involved lung segment. That is a ton of time for us. 3 minutes of doing this, man, that's a ton of work for us. So depending on how many segments are involved, yeah, it could be. Well, we'll get that. But best when also used in the position of postural drainage. So one, to position of postural drainage typically puts the areas that I want to work on exposed. So I can, right. So if they're leaning forward because of posterior side, it gives me access to that. Side lying, I get access to the side that's this. So it's really, I've never seen, well, I've done this to a guy with Alzheimer's and he can't change positions easily. It would take us 40 minutes just to get him into side lying, never mind with the feet elevated. So, but anytime we're talking about percussion, you should think in the postural drainage positions unless you can't for either contraindications or some other mobility restrictions like that guy has. Precautions include history of rib fractures, flailed chest. Flailed chest is fracture of 3 adjacent ribs. People with flail ribs, the chest walls can move and separate independently of one another. So that's not great. Osteoporosis, the risk of fractures of osteoporosis, elevated coagulation, and decreased platelet count. I will say that guy that had I was always a little skeptical. Like, I feel like I'm just hitting somebody. Like, does this actually work? And especially when we're not, it's one thing if we can do this and the patient coughs and gets mucus out. That is our signal that yes, that this worked. That's just like the shoulder going up an extra 30 degrees after joint moves. But we don't always get that. So I was always skeptical, like, am I actually doing it? If this person isn't after 3 to 5 minutes, if they're not getting rid of stuff, is this actually working? So the last time I had to do this, I did it with that guy that couldn't change positions. And I had his pulse ox on the entire time. When I walked in the door, he was at 83%. After 89%. And at the end of 3 minutes, he was up to 93%. So, and he can't cough on command. He doesn't understand that. So he didn't cough anything out, but just by mobilizing these secretions, the lungs were able to efficiently perfuse and get oxygen and ventilate the rest of the blood. So it was so nice. I don't know why I haven't done that at any other point in my previous 15 years, just to say, does this actually work or not? But yeah, I was blown away that it actually worked, and even without that outcome of he just spit something up. So it is definitely a great tool to have with us. So let's practice this for a little bit. You as a patient, you come up with your algorithm. Pick one of this row, one of this row, and one of this row. Challenge your therapist to put you in the appropriate position. And then let's add our percussion techniques that we already have learned. So remember, cupped hands, because it's the not only the impact of our hands against the thorax, but it's also the air that's going to be vibrating through their cavity and creating that vibration to move the secretions around. And you can almost hear when you do it right, when your hand lands and it gives that crisp pop sound, like you can really hear the difference between like a good hit and a bad hit. That's this weird phrase for so try to see if you can hear those differences between a really good cupping technique and then some that are not so good. You'll hear that pop really, really well. So challenge your therapist, come up with your own algorithm, challenge them, and let's only do about a minute of percussion for now. Yeah, when possible. Yeah, I think one of the things in physical therapy that we should always do is visualize as much tissue as we can. If we look in any of our textbooks, the MMT textbook, the first sentence of the first chapter says, have your patient remove all of their clothing. And you go, well, I don't think I need to do that for a quad MMT. Oh, you got to do it. So I think it's good practice to do with as little clothing as possible. Yeah. What that means for us, there's a comfort level of our patient. There's a comfort level of you as a clinician. Me to a female patient, especially if we're in a private room, I am much more careful than if I had a male one. Maybe I shouldn't have that difference, but I will just tell you from my perspective, I am more careful. So whatever makes sense to you and your patient. A lot of our patients, if we're in the hospitals, they're in Johnny. Yeah. So, and they're already there. So sometimes that's taken care of for us. So let's spend a few minutes doing this. So if you can see these pictures, right? So the airway comes down, breaks into left and right, and then breaks into segments that go up. In order to unclear these upper lobes, we need to get that mucus to the larger airways first, and then once it's in the larger airways, it can then go out through the mouth. So we need to get it unclogged here. So we got to make it go down into these bigger airways, and then it can go out from there. Does that now make sense why the upright position it makes sense for the upper lobes? Yeah? Okay. All right. So then, man, we did a lot today so far. Jeez. Thank you. Where were we? All right, shaking and vibration. I'm not making it. Yeah. I wasn't planning on it. No.
Yeah.
All right, hold on one second. I am recording this. So I think the way you phrased it was very nice, but maybe we can talk about that if we have time after. I don't know if we're gonna have time, but right now let's get into shaking and vibration. So the shaking and vibration, that's a bouncing maneuver with the therapist open hands during expiration. So again, if we can, we like to be specific, apply to the thorax over the involved lung segment. So again, I know when we started with listen to the lungs, that's not typically a skill that's crucial for our careers. But the better you get at that part, the better we can be specific to these treatments and where do we have these treatments. So shaking vibration, apply the thorax over the involved lung segment if we know what it is. Patient takes a deep breath in, and then we start shaking during the exhalation phase. 5 to 7 breaths, usually used after percussion, and then all the same precautions as percussion. Okay, so Al, can I have you back up in sideline, please? So I like to do when I do my vibration techniques, I like to have both hands usually anterior, posterior of what I'm looking at, although sometimes I just can't. So can you just slide to me just a little? So I like to be here, then we go, okay, deep breath in and then out. And I give quick that way. I do. Yeah, no. And I could, if I needed to do it this way, big breath in and then out, and then I can do it just that way. Okay. Oh, Alan's doing good. Alan's breathing. Where's his SpO2? He's breathing like a champ now. So that's my vibration techniques. I like to be on, if I can, anterior posterior. I feel like I get the most amount of compression and shaking that goes along with that. But sometimes I can't. I just got to do the one side if I have to. Okay, does that make sense? So this one is again, it's a lot of work for us. But again, I don't think this is a difficult skill to acquire. The only thing that we have to be really careful of is not adding too much force, especially if somebody is osteoporotic. Now I'm really concerned about the amount of force. This is force, so both of these last ones. So, for my money, I would rather, man, if somebody's got osteoporosis, what would you do? We've learned a bunch of things today. Osteoporosis, they're frail. You're worried about it. I'm all set with you, Alan. Thank you. What other options? What plan B would you have?
Instead of this and the cupping.
Yeah. Let's say you as a therapist decide cupping, percussion and vibration. This patient has too many precautions. I just don't feel right about it. So just postural drainage. Good. What else? Yeah, any of those other devices, the acapella and the flutters, I think were the two ones there that's exactly what I would do. My hands can't go on this person because I think I'm going to hurt them. Here's a little, anytime a $30 piece of equipment can take our place, I will gladly let it. But the downside of this, that's non-specific. Here, what the benefit is, we get to be specific to the section that we heard was a problem. We get to be specific to that. So it's what we do is superior than just those. But if we can't, yeah, we got a backup option, definitely. So let's get back, pick a new position, and then do some shaking. Okay. Yeah, that's what we talked about earlier.
Very expensive, but it's not like and
So, a lot of great questions about the shaking and vibration. One thing I'll say is the shaking and vibration is almost non-specific. However you think you need to or can do it is probably the right answer. I don't think grabbing Alan's shoulders and shaking him back and forth and having his head bobble, that's probably not it. Yeah, well, he's a little old for that. I know he's a young guy, but he's probably not at risk for shaken baby syndrome anymore. Yeah. But I think any it's non-specific. So we had great questions. Steph asked, well, how much force are we applying? A lot of force? And I don't know. Yeah, probably some, maybe a lot more for other people. It's non-specific and it should just be what feels right to you. Now, one thing I'll say is as you're doing it, you don't want to just move adipose tissue. Like if you just grab my lateral side, like just don't move my adipose tissue around. That's just entertaining for you. It's nothing for me. So like again, what is the goal? The goal is to get the air that's in the lungs that are being exhaled to be vibrating so that we can mobilize mucus. And if I could do that with the ribs as well, get that goal accomplished. And again, I think the easy way to do it is for me on either anterior posterior or right and left lateral to do that, because I feel like I get a ton of compression. I can really get that air going that way. But however makes sense to you, that's the way it's got to be done. So again, non-specific. The percussion techniques have a lot more rigid we've got to make sure we have those domed hands and light wrists. So there's a lot more specifics to that. Postural drainage, very specific. This lobe going in this direction. The vibration and shaking is a lot more non-specific. Do whatever you feel like is important for that. I think the key though is on expiration for that. Any other questions? So one thing I will say for all of the things we've just covered, make sure you have Kleenex and trash bins around. Because while I've seen SpO2 increase without mucus clearance, the goal is mucus clearance. The goal is to have a productive cough that we can say, give me that, and then you get to throw it away. So be ready for that. That might mean additional PPE. That might mean changing where you're standing in front of the patient. And again, definitely means Kleenex, paper towels, hand sanitizer, trash bag, like all of that needs to be around. Same thing if you got a patient with vertigo, have the trash right around because it just takes one, hey, look over there, and all of a sudden their headroom's spinning and they might vomit too. So, oh, you didn't witness that?
No.
Oh, that's too bad. Yeah.
But we got close, but I didn't see any.
Well, that's good. Next time you get them all the way there. So after we do these secretion mobilizations, postural drainage, cupping, and then the vibration, we are going to encourage coughing and or huffing. So coughing is the most common and easiest method. I think we all understand what a cough is. So again, I love when I don't have to teach my patients a lot. I hate when I have to teach them a lot because the pelvic tilting or breathe into my hand, like it just, for some reason, it gets really tough. But coughing, we shouldn't really have to teach them. All we have to do is tell them we want to inhale maximally, hold your breath for 2-3 seconds, then cough forcefully 2 to 3 times with your open mouth, and hopefully we get some clearance of this mucus out. Some of our post-surgical patients, we might need to splint with holding a pillow, so you can definitely grab a pillow for them and they get to hold on to it. That's going to be a powerful technique, especially when we go into cardiac surgery. That's going to be something we do all the time. So get in a good habit of just having that there. So if they have open heart surgery and we have precautions on this, we want to be able to splint this so we don't mobilize all of the incisions, and also in that open heart surgery, the sternum that was cracked open. So we're just giving some bracing for that. So coughing is fairly easy. Huffing is an alternative method, really beneficial for those patients with obstructive pulmonary disease because huffing doesn't close the glottis. Therefore, it doesn't create a spike in interthoracic pressure. So also helpful, huffing might be preferred for people with high blood pressure as well, because that increase in pressure will spike blood pressure. Same procedure, except now instead of a forceful cough, the patient is instructed to huff by saying ha, ha, ha. So big inhale in, and then hold for 3 seconds, and then ha, 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 right? So now we're not closing that glottis to create a lot of pressure. We're having that pressure stay open. So everybody, we can practice real quick that huffing technique. So big breath in, hold for 3, ha, ha, ha. I wish somebody was walking by right there. I would have claimed I made a funny joke. So I will say, I think coughing is an easy one for a patient to understand, but huffing, because we don't spike that intrathoracic pressure, it's probably safer for most of our patients. You know, if they have pulmonary conditions, they're probably going to have some cardiac conditions as well. So I think the huffing technique is probably a lot better. Diaphragmatic breathing we already talked about. Segmental breathing we already talked about. You might see segmental breathing also called a lateral costal, localized breathing, or lung expansion. I see it most often segmental, but you might see it in those other ways too. But we're all talking about the same thing there. All right, active cycle of breathing. So an independent breathing exercise program a patient can perform to clear secretions. Goal is to move secretions from smaller to larger airways.